Thank you, everybody. We'll get cracking, I think, with the second half. See how we get on. I would like to introduce you to Donald Yool, who he qualified in Glasgow sometime in the past. I didn't ask him that bit, but he seemed really about it, really. Donald hails from just outside Elgin at Pluscaden, where the monks live. He comes from, I don't think that's very relevant, but no, he doesn't come from the Abbey, but you know, we're working on it anyway. He's a, he comes from a farming background, from farming stock there as well. So I'd like you to introduce you to Donald Yool to talk about tumours.
Is the question or the presentation of Donald?
We do the questions at the end.
We'll do the questions at the end. Yeah, that'd be fine. Thank you very much.
Okay, well, hello everybody. What I thought I'd do is a lot of my stock in trade is removing lumps and bumps, and I say it's a good topic to kind of go through because I think there's a lot that you can take into practice from the core principles of tumour resection. And when I do this sort of talk, I usually base it around 3 relatively common tumours I'm sure you'll come across, and I try and use one of the most extreme examples of a mast cell tumour just to kind of demonstrate how you can use pretty simple and straightforward techniques and still get a really good result. I always feel a bit of a fraud when people send cases to me for mass removal because a lot of the surgery that I think they always expect I'm going to do grafts and flaps and all of this really fancy soft tissue surgery, but actually most of the time a simpler surgery will achieve a better long-term result. So on the whole, we try and keep it as simple as possible for reconstruction and try and avoid the more advanced techniques. And then when we get those out, we get them out for very specific reasons. So I'm going to focus on a more kind of core approach to soft tissue surgery for skin tumours. And I'll run through the 3 kind of common examples which give you the 3 different grades of surgery that you might consider. So my plan's really to go through lipoma, histiocytoma, and mast cell tumour in that order, which nicely kind of ranks up from very, very simple to tumours which need a bigger margin of resection. And I think when I do this, I could pick mammary tumour as easily as I could pick histiocytoma. We deal with them from a very similar perspective, from a surgical perspective, from a cancer treatment perspective in terms of margin. And similarly for a mast cell tumour, soft tissue sarcoma, which is the other really common problematic soft tissue tumour that we see usually subcutaneously, often on the distal limbs of dogs. Really, really commonly, we can apply a very similar approach as we would to mast cell tumour and get very similar results. So they're nice comparisons. So they cover the majority of the tumours that we'll see in the skin and the subcutaneous space in dogs and, to a lesser extent, cats. So there are a few sort of things I think it's always worth kind of debunking when we start looking at this. The first is the mythical tumour capsule. And unfortunately, the reality is none of the tumours that we commonly deal with really have a capsule that is an effective barrier to anything. And what we really see is the pseudocapsule. And the pseudocapsule is just the tissues surrounding the tumour that get compressed as the tumour expands into that space and begins to shove them out of the way. And because, again, I think we often think about tumours growing from the centre outwards, and they actually tend to grow from the periphery and just expand from the periphery, what we see at this transition between the tumour and the healthy tissue surrounding it is this compressed region which forms this apparent capsule, but what it is generally composed of is a combination of healthy cells, inflammatory cells, and tumour cells. So when we're looking at effective surgery, unless we're dealing with incredibly benign tumours, that capsule is never sufficient for us. So unless we're dealing, as I say, with very, very benign tumours, if we remove at the pseudocapsule, then the likelihood is that we'll be leaving tumour behind. And although that doesn't necessarily mean to say that we'll always get recurrence, it obviously increases the risk of recurrence dramatically. And then the other big question is, how much tissue should we remove? And I always think people get very upset when they spend hours taking 2 to 3 centimeters around a mast cell tumor, and then they get a histopathology report which says you've got 5 millimeters for all of your effort. But there is a big difference between what we see as a gross margin and what we'll achieve as a histological margin. And part of that is because of the microscopic extension of the tumor that we'll see into the surrounding tissues. And part of that is through things like shrinkage artifact, which occurs when we fix tissues. They tend to shrink down under fixation. So when you start with these really big gross margins, what you will get is generally a much less impressive histological margin. So for me, if I take a 2 to 3 centimeter margin around a mast cell tumor and I get a 5 millimeter histological margin, that's fantastic. That is absolutely what we're aiming for. That would be a really good margin to get surgically. So it is important to know what that margin is, and it's important to recognize that your histological margin is going to be much smaller than your gross margin. And as a general rule of thumb, anything beyond 5 millimeters is generally a great margin for tumor resection when you look at the histology. Anything less than 3 millimeters, unless it's benign, then you're coming into that category where recurrence increases in its likelihood. And if you have no margin, the risk of recurrence is high, but it's not always 100%. So things like soft tissue sarcomas and even mast cell tumors, the recurrence rate is actually quite dramatically less than 100%, even with these very narrow margins. It's not always terrible news. So the other thing is, I think when we're taught this, we're often taught just this very kind of basic, we aim for 1 centimeter, we aim for 3 centimeters. We're given this metric margin that we can measure with a ruler. And that's absolutely fine on skin, because we have lots of skin, and it spreads around the whole body of our patient, and we can achieve a good margin of skin in these types of measured margins for the majority of our cases. But for pretty much every patient you've got, unless it's a 90 kilogram Great Dane with loads of body fat, to get a 2 to 3 centimeter margin deeply is going to be a highly invasive surgery. And when we look on the limb, particularly below the stifle and below the elbow, when we look at margins of that nature, they're just unachievable without things like amputation. So that metric or that measured margin is a good margin to consider for the skin. But when we look at the deep margin, then what we should be really thinking about is looking more at what forms really effective barriers to tumor extension. And we should be aiming to remove that, rather than worrying too much about what that actual depth is. Because as I say, we're just not going to achieve these types of wider margin for the majority of our patients deeply if we look at a measured margin. So what forms effective barriers to tumor extension? It's essentially any thick, fascial or collagenous tissue that we might encounter. So muscle belly is always a good option, and the thicker the muscle belly, the better. Any sort of defined muscle underneath your tumor will form a really effective biological margin to tumor spread, with the one exception of the panniculus muscle or the cutaneous trunci muscle, that really thin layer of muscle which sits just below the skin and above the subcutaneous fat, which is incomplete and very thin. That will never form an effective barrier to tumor extension. But when we come down below that, any deeper muscle plane will always form a good barrier. And usually muscle is usually what I aim for when I am doing these types of surgery. We can also use fascia. So on the limb, for example, the tensor fascial artery, again, it's a great margin for tumor extension. It's a collagen sheet. It's pretty impervious. As long as the tumor isn't adherent to it, then we should be fine. That should form a pretty effective barrier to tumor extension. The other really good area of fascia is over particularly the abdominal wall, where we have the external rectus sheath, our outer layer of fascia from the aponeuroses of the abdominal musculature. And if we remove that, then again, that gives us a really good margin to tumor extension. We always talk about periosteum, and if I have no other option, I'll strip periosteum back. But bone also is good, so if I can take the bone underneath, that's what I will do. And for most people, when we come to removing bone or periosteum, then we're coming into the realms of more specialist surgery, and not so relevant really for what we're looking at today, and more really for things like the oral tumours and things that we see, in which we'll often remove the underlying bone. So these are things which make good margins. So what we tend to do when we're looking at resecting tumours is we think about a hybrid approach. And that hybrid approach is just deciding what on balance gives us a good margin of skin that we can measure with a ruler around the mass to remove, and then how deep to that do we need to go, thinking about it in terms of those biological barriers to tumour extension. And we have two basic options when we look at the deep margin. We can either go to that next deep margin and leave it in place, or we can remove that deep margin. And those will give us our two core approaches to how we work out how much tissue to remove deeply. So, mast cell tumour, and I'll show you this case from start to finish. Speed it up, you'll be glad to know. Just kind of go through how you put all this together into how you manage a case. But mast cell tumour, for example, then what we'll be looking for is something like a 2 to 3 centimetre peripheral margin or radial margin around the mass of skin. We're going to include the subcutaneous fat and any panniculus muscle in that. And then we want to go and remove the deep fascial plane to that. So in this situation, we'll go down and we'll remove the deep fascial plane. And for this case here, these are always actually pretty straightforward cases in many ways to deal with, even with quite big resections. This is a mast cell tumour over the abdominal wall, where we can go and take out the external rectus fascia and the underlying muscle to give us that deep margin, accepting that for most situations those muscles are redundant and the other muscles which are in place will be more than adequate. And that's certainly the case for these types of tumour. So there's another thing that where you really don't want to spend your time doing a massive skin resection and then work your way down towards the center of your incision and the sort of conical dissection as you go, because the only difficult part of reconstruction is the skin, and unless you achieve a good wide margin around everything, if you make a big skin incision and you take out much less fat and then even less of the underlying fascial plane, then you'll leave yourself with a large skin incision, which will be problematic to close without getting the benefits of taking that large amount of tissue out. So when we're doing these surgeries, what we need to be mindful of is to remember to make our skin incision and then work down perpendicular to the skin till we reach our deeper plane before we start to come in and detach it. So rather than ending up with these sort of kind of more cone-shaped dissections, what we want is a much more perpendicular resection to the skin, down to the next fascial plane. So this is your mast cell tumour. Oh, I've turned that off. That wasn't intentional. If you imagine this is the muscle here, this is our 2 to 3 centimetres around the skin. We want to come straight down until we hit that fascial plane there, perpendicular to the skin edge, so we make sure we get 2 to 3 centimetres of subcutaneous fat, and then we include that length of the deeper fascial plane to get that deep margin of resection. So, start with lipoma. There's nothing I can tell you about lipoma you don't already know. It is as simple as you imagine. Lipoma is completely benign, so they don't really interact. The pseudocapsule is just compressed normal tissue, and we can do a marginal resection, which is just a shelling out resection where we just open over that and peel it out of that fascial plane on which it sits, and that will leave us with a very low risk of recurrence. And I'm sure this is what we're all used to doing. There's no point in complicating this and trying to take out more skin around this. It won't do anything to improve outcome or reduce the risk of recurrence. And a very straightforward, simple marginal resection like this is fine. So a marginal resection, unfortunately, the only tumour that it's really applicable to that we see commonly is the lipoma. Fortunately, it's about the commonest tumour that we see in general practice, so it's a good one to do. And in this, we just need to come to the pseudocapsule. We don't need to consider any deeper plane or any deeper biological barrier, and that's going to be our primary resection, our primary closure. What I can do with lipoma is to tell you when you need to be cautious that things may not be quite as simple as you expect. So there are a couple of scenarios I thought would be sensible to bring out. So lipomas around joints are always a little bit trickier, particularly on the forelimb, I'd have to say, because they're often close to or encircling neurovascular bundles, and there's not much space in those areas for that lipoma to find a nice route around it. And what lipomas tend to do is when they meet something like a vessel or a nerve, rather than pushing to one side of it, because they're so soft and compliant, they tend to just grow up around it and envelop it. So although we'll still have a plane that we can dissect down to that nerve without disturbing the tumour, it will be essentially encased or cuffed by the lipoma. Ones between muscle bellies, particularly of the hind limbs, can be more challenging. On the hind limbs, they're far more likely to be wrapped around the sciatic nerve, is really common. And on the whole, they can be removed without damaging that, but you need to be aware of that before you start. And ones which are not freely mobile under the skin fall into two categories. The vast majority, say you have one over the thorax which feels immobile, it's not really moving about as you would expect a lipoma to do. Most of the time that's just because it's between the next deep plane of muscle. If you go down into that muscle, through it, you'll still be able to shell it out. But occasionally it will be this particular type of lipoma that we see occasionally, which is the infiltrative lipoma. And the infiltrative lipoma is the lipoma which will merge into the muscle fibers. It will push its way through ribs or through the abdominal musculature. It will end up invading into body cavities and into other structures. Resection is much more likely to cause major functional problems to the patient, and the risk of recurrence is much, much higher. So I've got a couple of examples of this. This is inevitably the head nurse's dog from Edinburgh Vet School many years ago, Diane MacDonald, if any of you knew Diane. So this is a lipoma I agreed to remove from her dog Angus against my better judgment. And what you'll see as we come into this, you'll see that on this caudal aspect, we'll begin to find one of the major neurovascular bundles, and it is being wrapped around the lipoma. So all I'm doing is just that shelling out approach. I am taking my time because I am aware that there may be issues here, and you'll see it begin to emerge in a second. So I think you always need to be a little bit more careful, particularly around the elbow like this, that you may be trapping or getting close to these structures. And what I'm actually going to do, you can see that's the vessel there and nerve. And what this is doing is it's got a branch and the lipoma is crept underneath that. And what I'm actually doing next is just trying to push it underneath the blood vessels without rupturing them. And most of the time you can do that. Most of the time these are fine, you can get these out, but you need to be aware of that as a risk. So these types of tumor around joints, in these areas which are inaccessible, It's far better to address them as early as possible before they reach these larger stages and before these critical structures get involved or become difficult to evaluate. And this is, we do CT quite a lot of lipomas, particularly the large lipomas and particularly lipomas between muscle bellies. It's an instant diagnosis lipoma on CT because this is just fat that we've got, but this one has two different features. So this is one in between muscle bellies of the hind limb. So we will have the sciatic nerve running down here, adjacent to or through the center of that, so we need to be careful of that. And then this is a double whammy, because not only is this an intramuscular lipoma in the hind limb, but if you see up here, we've got all these striations through this muscle. This is an infiltrative lipoma. So this lipoma is invading into and ablating one of the major adductor muscles, I think, of this dog's leg. And this patient goes from a patient in which we can scale up that simple lipoma surgery to a patient that actually needs a amputation, which is really the only way to deal with this one. So these large lipomas on the hind limbs and things generally can be far more problematic to deal with from both of these counts. So the next group is the kind of the local resections, and these are the ones we would reserve for the benigner masses. So the histiocytoma is a great example. Mammary tumors are also a great example. This is the basic surgical approach to mammary tumor, is to remove it, essentially just with 1 centimeter margin around the mass and going down to the next fascial plane, but not through it. So for these benign tumors, that approach is likely to be curative, and taking more tissue is unlikely to improve the outcome at all. So it's a really good option. It's also a really good option generally if you've got a small mass and you want to biopsy it, because if it is benign, then that is likely to be curative. And if it's not benign, as long as you've kept it, as long as you're dealing with a small mass and you're keeping within these relatively small margins, it doesn't limit too greatly what the future options are if you need to go back and revise that at a later point. So those are the two which I think are very straightforward to deal with on the whole. And then we come on to the wider resections. And the wider resections is what we'd reserve predominantly for things like the mast cell tumors and the soft tissue sarcomas. And as I'm sure we're all aware, these are the ones that we will see pretty regularly, and these will be the problematic tumors that we see. And with these tumors, we're dealing with tumors which are more invasive locally, so they will have microextensions of tumor into the surrounding tissues. So we need to aim for a pretty wide resection around them in order to capture those microextensions and to make sure that our histological margin is sufficient to reduce our risk of recurrence within the skin and the subcutaneous space. And then we want to come down to the next deep fascial plane and remove that so that we ensure that any of those microscopic extensions coming down towards that next really strong barrier to tumor extension will be captured by removing that deep biological barrier. So we used to say 3 centimeter margins for mast cell tumors, and that is a bit of overkill. So as long as you're dealing with a mast cell tumor which is not particularly large, and for particularly large we'd say over 3 centimeters perhaps in diameter, and as long as you're not dealing with a mast cell tumor which has a particularly high biological characteristics, and those would be ones which are extremely inflammatory, going up and down greatly, rapidly expanding, or in patients in which we expect or suspect that they are spreading elsewhere. Unless we're dealing with those, then 3 centimeter margin is a little bit excessive, and actually 2 centimeter margin will give us generally as good a result. What I tend to do is draw out 2 centimeters and 3 centimeters, and then I pick whichever is the biggest margin I can, which gives me the simplest closure. And if that's 2 centimeters, I'm perfectly happy with that. If I can do 3 centimeters easily, then I will. But more often than not, I'm somewhere in between. So we're going to aim for that as a wide resection around the mass, And we're going to go down to the next fascial plane and excise that as well to get that deep barrier. So this is the one in question. So this is actually 2 mast cell tumours on the flank of a dog. So here we are measuring 2 and 3 centimetre margins around this. This is, we call this trying before we buy. When we pinch the skin together, make sure you can reconstruct it. If you can get it together easily before you start cutting, it should be easy to reconstruct after you've excised it. So one of the things I wanted to point out here is you'll see that as the surgeon here is cutting, the skin moves away under gravity and recoils away from where you've incised with the elasticity of the skin and the gravity of the situation. And what you'll see the surgeon is doing is she is keeping very focused on where that initial incision was. And I think I have an overlay in a minute just to show you where that original incision is. And she's making sure she's taking out and keeping going down till she reaches the deep fascial plane along that same margin, so that she doesn't lose that perspective of where that deep margin is and how much of that fat she needs to remove. And here she's coming down to the next deep fascial plane. In this case, she's taking out the external abdominal oblique, which is that outer and third layer of musculature along the abdominal wall. We've still got the transverse abdominis and the internal abdominal oblique muscles, which provide more than adequate support. And once she's detached the muscle, she'll then just come into that fascial plane and quickly unzip it, just taking out that with that deep fascial plane. And if you can't achieve a local resection with this surgery, the surgery like this, you're never going to achieve it. So this should give you a good local resection. So those are the margins we go for, but we then need to decide how do we put this together when we end up with one of these massive incisions that we've made. So the absolute critical goal of reconstruction is simply no tension at the skin, at the point of closure. So whatever you have in terms of tension, you want to deal with that in all the layers deeper to the skin before you get to the level of skin closure. So ideally, when you're putting in skin sutures or an intradermal suture pattern, the skin is just sitting next to itself without any tension, without any pulling apart. So the way to deal with this is to get rid of that tension by distributing it as much as you can into those deeper layers of tissue. And we'll go through the basic techniques, which I'm sure you're certainly aware of, are key one, I'm sure, and we'll look at some of the other ones that we can use to help us. When you have these circular incisions, the other thing to aim for is wherever possible, try and convert them into some kind of linear incision. Now, that doesn't mean that it needs to be a straight line, but what it means is you shouldn't have 2 different suture lines intersecting. So when we end up with squashing tissues together and deciding, well, I can close these bits together in a straight line, but I'm going to have another branch of my closure coming off at, in a Y-shaped closure because of the way the tissues are, where you have those intersecting lines, at the point they intersect is quite a high area for dehiscence, and your risk of wound complications is higher. So if you can achieve it, converting it into something which is just a single suture line, your outcomes will be better, you'll have less wound complications to deal with. Ignore dog ears. Say dog ears are, nobody in my world worries about dog ears. We're delighted by a dog ear if we have a wound breakdown because that's useful skin that we can use for reconstruction. To get rid of a dog ear, the only way to do that is to remove far more skin than you had planned in order to reset the skin associated with it. And again, generally, removing dog ears will increase complications and leave you less contingency for managing wound problems or wound complications. In our patients in particular, within 2 or 3 weeks, the dog ear will have flattened, the hair will have grown back, nobody will be any the wiser, And the only thing that I do is I tell the owners this is a dog ear, and I don't care, because that's the sort of thing that they will worry about. But I think as long as you just set their expectation, this is absolutely fine, then there's no strong rationale for removing them. I also put here, avoid flaps if possible. One of the reasons to do that is if you're looking at treatment which may go on to look at other forms of treatment, which is more relevant, I suppose, in referral practice than it is in primary care practice, then anything with a poor blood supply tends to be more prone to complications with follow-up treatments. So on the whole, try and keep the surgeries as simple as possible and avoid large flaps or grafts or things of that nature. So how do we deal with that? Well, the absolute bedrock of reconstruction of these larger wounds is just the really humble walking suture with undermining, which I'm sure we're all familiar with. The key things for me about this is where you anchor it. You want to anchor these into good, strong fascia. So deeply you want to come into the muscle or the deeper fascial plane. In the skin, you want to take your needle and not go through the skin from the subcutaneous space, but you want to scrape it along the very collagenous dermis, so you're catching the really firm subdermal areas where all the fascia is. The other thing is, don't try and achieve too much with any single stitch. So what I'm doing here is I'm just pushing the skin, seeing how far it will move. So what I'm going to do is take this bit of skin as far as I can take it reasonably, which will not be all the way across this wound. It'll just be to about there. I'm going to anchor that in. And shift the skin that far. Now, what we're doing, these are not tension relieving techniques, as they're often called. They're tension distributing techniques. So they're taking tension and they're dealing with it at each point of stitch. If you put in one stitch and you put all the tension on it, that will fail and your wound will break down. So what you want to do is multiple layers of these and multiple sutures in each layer. So as a general rule of thumb, what I'm doing here is I'm doing 2 layers of walking sutures. So that first layer is taking that skin halfway across the wound that I'm trying to close. The next one is going to be a little bit closer to the edge, and it's going to push it even further towards the edge of what I'm closing. And I would put in maybe 10 stitches in each of those layers and just push that skin forward and distribute that tension over multiple stitches. And the third thing and final thing really about closure, when you do these bigger resections, what you've done is you've come down into these deep fascial planes, and you should use those to facilitate your reconstruction, because those deeper planes are attached to your more superficial planes. If you move the deeper plane in towards the center of the wound, you'll shift everything superficial to that closer, including its blood supply. And that means that when you come into those more superficial areas, you'll have much less space to cover, and there'll be much less tension in those more superficial layers to close. So this is a dog with a melanoma on the back of its head, which we removed with a 2 centimeter margin. We ended up with this incision. We'd planned to do an advancement flap, so you can see we've drawn out the flap margins there, but we've got 2 distinct layers of fascia that we've cut through on the caudal aspect of this. So what we decided to do was we just start to close those deeper layers and advance the wound as much as possible as we could. So we took the first one up to the base of the skull, and we've halved that wound and taken out a lot of the tension with that closure. And then we took the second one right up to the fascia on the head, and that left us with this closure where we took that large wound and we just distributed all of that tension in the deeper layers, shifted everything forward, and ended up at a point where we don't have any tension at our skin for closure. And this was very straightforward to close. So putting that together for this case, we're doing a little bit of undermining here of our muscle. And then we're going to use that as our first layer to push forward. So what you want, for these deeper layers, you want to use a longer lasting suture material. So I generally will use PDS or something like that. If you have biosin, that's a good choice as well. You don't want to use a monochrome because it will be really strong on day 1 and really weak on day 7. So it's just not going to last long enough for the skin to heal properly on top. And you can see as we're doing this, we're just pulling all of that overlying tissue in towards the center. So that's our first deep fascial closure. The other thing about this, we have managed to close those muscle bellies together, but for these deep fascial closures, you don't need to get them back into one complete piece. You can just advance them and tap them to the underlying areas if you're still and this is what we'd call a linear closure. So it's not a straight line, but it's a single suture line that we're doing rather than one which is bisected. So what we've done in those more superficial layers is we've done a subcutaneous fat layer with, I usually use a relatively heavy gauge monochrome for that because it will give you a little bit of tension support. In this case, we also had a nice panniculus muscle. So although that's of no real value as a tumor barrier, it's great for suture anchorage for these more superficial reconstructions. So we'll reconstruct that and then the skin closure. And the other thing that we did a lot with this case is we used, where we could, continuous patterns. And continuous patterns distribute tension really well and really evenly through the wound. So they won't be great where you're dealing with large amounts of tension, which are in the deeper layers. Well, the last maybe 2 things. I don't know if Tony's going to. So the last 2 things I thought I would do would be the other things that you can do to improve your treatment options or your assessment of your patient, that kind of thing. So one thing which is really prevalent is lymph node removal at the time of mass resection. And we used to think that this was largely just as part of staging to work out what the extent of disease was. But actually, there is quite strong evidence that for things like mast cell tumor, removing an affected node is actually really valuable therapeutically. And that may take you from a position of needing follow-up therapy to not needing follow-up therapy. So node removal also can be considered more therapeutic, as it is in people, in which node removal is done a lot for therapeutic purposes rather than just diagnostic purposes. So lymph nodes fall into 3 categories. They're very straightforward, the tricky but very achievable, and then the complicated ones which will challenge you. My absolute rule of thumb for a lymph node is tell the owners you'll try and remove it. Don't promise it will come out, and set yourself a time limit of 20 minutes or so to do it. Because often node removal will take longer than any other part of the surgery if you're having a bad day or if the node is difficult to locate. So for the mandibular lymph node and the popliteal lymph node, the ones you can feel really easily subcutaneously, they're very straightforward. You just need to make an incision directly over them, bluntly dissect down through the fat until you reach the node, and then pull it out of the tissues and bluntly dissect the fat away, and they will come out very easily. There's very little to go wrong with those. You'd have to be really off course to end up with hitting something like the popliteal artery for a popliteal lymph node. It's very, very deep to your area. Mandibular node, the only thing you can do is remove the salivary gland instead of the lymph node, which isn't a great thing to do, but you should be able to feel the salivary gland and the lymph node in front of it. And if you can't do that, then I wouldn't try and remove it, because you don't want to make that the first time you do a cyeloadenectomy when you think you're popping out a mandibular lymph node. Probably no harm will come of it, in all honesty, if you do it. You won't have a happy week, though. Then we come to the pre-scapular lymph node. Now, pre-scapular lymph node is relatively straightforward, but there's a big trick to it. So the arrow points to where the lymph node can be palpated, and the incision is below it. It's not directly over it. And that's because the lymph node hides underneath a belly of muscle. And the belly of muscle goes from the shoulder up the neck in the same kind of orientation as the arrow. So if you come down onto the lymph node, you'll hit muscle, and then you will struggle to find the lymph node. If you come below the lymph node and you come underneath the muscle, then that will take you into the space where the lymph node is, and then with a bit of guddling about, you should be able to pull the lymph node out. The prescapular lymph nodes, they're not very easy nodes to remove until you get your eye in on, for them, so they're definitely a challenge compared to mandibular or popliteal, but they are achievable nodes for you to think about. Big nodes are always easier than little nodes as well, so if you're starting these, pick a massive node, and it should be straightforward. So here we're just trying to dissect along. You can just see the muscle belly emerging there, just that slightly darker tissue above where we're cutting. So I'm holding the muscle belly there, and that lymph node is sitting underneath that. You see there's a bit of judicious editing, because we then hit the blood vessel supplying the lymph node, which is very common, and everything bled, so I decided to take that out. I can't tell you, if you do have that, generally it's usually a good sign. You're usually very close to the lymph node at that point. Yeah, there we go. So then, hey presto, there's the lymph node that we've popped out of its space. I'm just going to pop it back underneath the muscle in a minute, just to show you where it sits. You can see the muscle quite nice at the top there. There's the lymph node almost removed. And then at some point I'll pop it back underneath. Here we go. So that's where it comes from, okay? So then we come on to the really challenging nodes. The axillary lymph node is a bit of a nightmare. I wouldn't recommend that you try unless it is really big. It's close to the brachial plexus and things, but it's not at the brachial plexus, so your risk of injury is very small. What I do for these now is I inject methylene blue into the skin around the node. That quite quickly gets absorbed by the lymphatics and goes to the lymph node, and it stains it blue. And that's the only way I can really find these unless they are really big. And even then, I don't get them all out. So I think these are generally quite difficult. You see that's the node sitting there, that little blue blob underneath the tissues there. That sits on top of the pectoral muscles about the level of rib 2, something like that. But unlike those other nodes, it's not particularly easy to palpate, and it becomes increasingly more difficult as you dissect over it to locate it in those deeper tissues. And then the last one is the retropharyngeal lymph node. This is a really common one for us to remove because it's really important for head and neck disease. So when we're removing the submandibular lymph node, we'll often pop out the retropharyngeals. When your eye is in, these are pretty straightforward, but there are a number of things which should worry you, and that is the carotid artery, the recurrent laryngeal nerve, and the salivary glands all sit in and around that. And these nodes are not ones you can directly visualize. They're ones you have to just go and pick up a bit of fat, pull that up. Is that the node? Put it back down and keep going until you find something which is node-like. And just try not to pick up the carotid artery when you're doing it. So they are easy nodes once you can do that, but they're not ones I generally would recommend people try. If I have a CT of the head, it will always be up because it helps to orientate. So I've got the mandibular salivary gland here, the larynx here, and our incision usually is going to be directly between the larynx and the mandibular lymph node, just as a linear incision along the neck, the dog and dorsal recumbency, and then just bluntly dissect between these two at the caudal aspect of the mandibular salivary gland, and the lymph node will just be sitting there. So they're not hugely problematic when you get there. It's just having the confidence to not worry too much about all these other structures that you really will notice if you cut the carotid artery. It won't be something that you will. A swab won't do it. You'll definitely need to ligate. Right, I think that's probably me. Thank you.
I think, oh, there we go. Tony's worn out now, so I've taken over. Thanks very much, Donald, and thanks, Roberto. Questions, anybody, for either? No, you've answered every question. There won't be any follow-up advice-seeking emails from anybody. We'll have a week free of advice. Great news. No, on that note, though, we are very happy to take advice emails on all the disciplines, so please feel free to email. The more information we can get, the better to help, so put it all in there. Describe it as the fluffy little white thing, whatever you want, but just put it all in and we'll do our best. If there's not any questions, I'll just hover. Oh, we've got one.
Good question. So, usually I prefer an overnight. Oh, sorry. Usually I prefer an overnight hospitalization because physiotherapy and supportive care need to start immediately after the surgery. So during the hospitalization, the first step I ask the nurse, it's a magic job of the nurse, to start with passive range of motion of the operated leg, uply high back. The dog will go home the day after usually. So I consider for the major part of the corrective osteotomy, so TTAs, TPLO, coracosion wedge, but also for CBLO, 10, 12 weeks of management after surgery. So the first 2 weeks I ask strictly rest, cage rest, only 5-minute walks with a leash, free for time for defecation, urination. Use the cone is very important because if the dog licked the wound, we don't have a lot of tissue here. And then progressively increase the level of control activity. So starting from the third week, like 10 minutes, 2 free time every day. The week after 15, we give a document with all this information to the owner. What I ask until I have the post-op X-ray that the dog have controlled activity. Personally, in a lot of situations, particularly if was a chronic condition, so it's month that the dog is limping, or if a second leg with the crucial ligament, I prefer that the dog start physiotherapy in the weeks number 3, 4. And then in a second step, when the wound is completely healed, also hydrotherapy. Years ago, we tell with TTA is not necessary physiotherapy because the dog start to use the leg more fast than with other technique. I notice a big difference between CBLO and other techniques because there was a couple of dogs where I did the TPLO in one leg and then the CBLO on the other. The owner was shocked about how fast is the recovery Usually in 6 weeks with the CBLO, you have a complete healing of the osteotomy. But generally, physiotherapy, particularly if it's a complicated situation, it's a second leg, is good to do. But for me, the management starts immediately after the surgery.
Anyone else? No, everyone wants home. Thank you very much again for coming. It's been a long time since we hosted one of these, actually. We had a quite a kind of quiet year for CPD last year, but we're back at it, and we thank you all for your support, those online as well. So if you haven't met any of us before and you would like to say hello, we probably know your name on emails, if not in person, so please say hello to us and introduce yourself to us. We'd like to meet you. And so on behalf of Tony and I, thank you very much to Donald and Roberto. The event was really organised by our nursing team and admin team. We took very little to do with it at all, so big thank you to you guys. They're stars, they really are. So thank you very much. And for our IT, whatever you call it, audio help here, the guys in the corner, thank you very much. To our sponsors, Agria, NutriVet, Veterinary Instrumentation, and also to Murray Canine Hydro at the back there. Please say hello as you go out. Roberto's done a good promotion for physiotherapy there, so know your local physiotherapists. I think that's all that remains to be said. So safe travels home, take some pizza with you, there's lots, so grab some pizza, chocolates, and hope to see you guys soon. Thank you.